I'd like to kick us off by bringing up our three experts in the field of HIV self-testing up to get us going and having a conversation around what HIV self-testing has looked like in the South, right? And to get some gems for the rest of the region. I want to go ahead and introduce you all one by one. First up, we have Robert Nelson, who is joining us from the Tennessee Department of Health. And is going to talk to us about how they've been able to launch an HIV self-testing program in Tennessee and some of the work that they've done to figure out the best platform to distribute their HIV self-testing services. So Robert, thank you for being here this morning. I'm gonna go ahead and pass the floor to you to tell us a little bit more about what's cooking in Tennessee.
Well, thank you very much, and I'm really happy to be here. I think the first thing I'd like to do is to thank my fellow colleagues at the Tennessee Department of Health who provided a lot of help and support to get our self-testing program off and running in a very short amount of time. And I'd also like to thank Brian Collins. Brian and I have talked over the years quite a bit about self-testing, and he's provided a lot of valuable information as well. So I'd like to start off talking a little bit about I guess pre-pandemic testing in 2019, the Tennessee Department of Health, we conducted right around, and I'm talking about rapid tests, right around 57,000 tests. We have 13 non-clinical community-based organizations based in Nashville, Memphis, Chattanooga, and Knoxville and Columbia, Tennessee. As far as clinical testing goes, we test in 4 EDs, emergency departments in Memphis, 3 emergency departments in Nashville, criminal justice centers in Chattanooga, Nashville, and Memphis, and 1 FQ or federally qualified health center in Nashville, which is the largest one in the city. So like I said, pre-pandemic, right around 56,000, 57,000 rapid tests. So I started noticing in January of 20 that the testing numbers were down quite a bit, about 30% for our clinical sites and 40% for our non-clinical sites. And as a matter of fact, in 2020, we conducted right around 22,000 rapid tests. So we had quite a drop off from 2019 to 2020. And then noticed that, you know, right around February, March, most of our community-based organizations had shut down, except for essential services. The emergency departments in Nashville had shut down as far as allowing testers, our HIV testers in the emergency departments. So we still knew there was a need for HIV testing. We participated in the Building Healthy Online Communities pilot. I think we were allotted around 300 tests, and nearly our entire inventory of tests was depleted the first 12 hours. So we knew we needed to be able to provide testing. And so we were able to purchase a quantity of the OraSure's rapid self-test and made those available to our community-based organizations throughout the state. I based the number of tests available to our CBOs based about like 50% of a monthly testing number. So we made those available, and then we encouraged the community-based organizations, the testing coordinators, to promote those via social media. We have, as far as distribution of the test, we have our own Tennessee. We have our own cloud system. It's a secure cloud where we can submit information. I have the community-based organizations submit their monthly testing numbers and positive test information through the cloud. So in order to save the folks postage and shipping and handling, I had them compile like a master spreadsheet in their TN Cloud folder. And every time they had a request for a test kit from a client, they would submit, add that to their spreadsheet. And basically what I would do, we have a corporate FedEx account. I would just go in and create a label, overnight shipping label, and just take a picture of it, do a snip and sketch program. And then I would just take a picture of it and then drop that label back into their cloud folder. And that way that it saved the organization the cost of shipping and handling. So that worked really well. Like I said, we kind of put this together on the fly and put it together really quickly. As far as and like I said, we had the community-based organizations promote their the availability of the self-test kit through social media. I can't share those, but anyway. And then we also encouraged the testing coordinators to incorporate Zoom testing sessions. Two of the community-based organizations one of the community-based organizations here in Nashville had a lot of success with the Zoom testing sessions. Two of the community-based organizations in Memphis did direct handoff to the clients and then got back later with them to talk about how to perform the test and the test results. As far as results and numbers go, we distributed right around 300 tests. We had a 70% rate of return as far as clients letting the CBO or the testing coordinator their test results. We tested, or the community-based organizations tested 4 positives, 3 new positives and 1 previous. 3 in Nashville and 1 in Memphis. So I was really happy with the rate of return. I did not expect that high of a rate. Like I said, it was right around 70%. I think it was something around 230 out of the 300 tests that we distributed. And as far as challenges go, there weren't really that. Just had me trying to figure out how to get the test to the folks. I basically ran everything out of my house, so it'd be nice to, if I thought I had more time to think about storage and where we're going to keep the test and kind of logistical issues. But it'd be nice to have my closets and the space in my bedroom back piled high with tests, and my refrigerator is full of controls and that kind of thing, but nothing really major. And I think the successes were evidenced by the rate of return and the positives that we were able to test. That's really all I have right now.
Excellent, Bob. Thank you. And I think you also named something that's important for us to think about, which is how collaborative this work is, right? And so you named Brian as being a supporter of Tennessee's program. And before getting into a conversation later, I want to go ahead and bring up Brian to share a little bit about the work that he's been doing in Virginia. So Brian Collins is a tester and HIV self-testing outreach worker in the state of Virginia that has really been a source of support for many HIV self-testing programs across the region. I know I've seen many webinars with Brian on them, and I knew that I definitely wanted to have you join this roundtable, Brian. So without further ado, I'll pass the floor to you, Brian, so you can talk to us a little bit more about Virginia.
Thanks, Jose, and thanks to the Latino Commission on AIDS for inviting me to speak. I'm very excited that this series is happening. I'm Brian Collins. I'm the Community HIV Testing Coordinator at the Virginia Department of Health in Richmond. And I'm going to talk about our Virginia and Maryland home HIV testing program just a little bit in brief before we get into actual discussion. And I hope that you guys can see my slides. So just to start things off with a little background, what you're seeing on the screen right now is an image that we produced in early 2014 that was a drive time map for every zip code, I believe, for every census tract in Virginia to the closest HIV testing site. And you can see from the picture that what we uncovered was that a fair amount of the state was somewhat inaccessible by drive to the nearest test site. Most of the test sites that exist are local health departments. We have about 130 of those that provide HIV testing across the state. In addition to that, we have just over 40 federally qualified health centers and community health centers, just about a dozen community-based organizations, and a collection of Walgreens pharmacies. For the most part, those organizations are located in population centers. So that's why you'll see in the picture patches of gray, and those tend to be focused around towns or cities. So as of 2015, when our program launched, many residents of the state still lived 30 minutes or more from the closest HIV test site. And the closest test site was usually a local health district, which might offer few STD clinic hours. And as I think folks on the call are probably, or on this webinar are probably aware, the clients that are most at risk for, or disproportionately impacted anyway by HIV, may frequently have had, previous stigmatizing or unfriendly experiences at the local health department. And so the local health departments weren't exactly our test sites best equipped to handle the people that we really wanted to focus on when we launched the program. So our program when it was initiated looked a bit different than it does now. We were using SurveyMonkey to conduct our pre and post test surveying, and our kits were just wrapped in brown paper and sent out for shipping through our state mail service. So you'll see a picture on the side there of our little intro screen from SurveyMonkey and what our test kits used to look like when they were packaged. Our eligibility was also much more restrictive than it is now. It was limited to men who have sex with men who were living in Virginia, who had not been previously diagnosed with HIV, weren't on PrEP, and hadn't used our program in the previous 90 days. So over the years, that's evolved. What you're seeing right now is the current information relating to our program. So as of midway through this year, we had removed our last demographic-based eligibility criteria, and now anyone residing in Virginia or Maryland is eligible to request a test every 90 days. And so you're seeing over on the right-hand side.
So sorry, could you slow down a bit?
Yes, thank you. So what you're seeing on the right-hand side is a picture of our new data collection instrument in REDCap that now starts with a question asking clients what their preferred language is. Additionally, we have changed our shipping system, and now our kits go out through priority mail as part of the Postal Service's regional rate program. And so you can see down in the bottom right-hand corner that has afforded quite a bit of additional physical integrity to the package, and also has given us an opportunity to put in some additional materials like condoms and lube. So I wanted to touch briefly on the impact of COVID-19. We've seen a really dramatic increase in test requests in 2020, and that started to really increase in March and has been especially pronounced since June, continuing through this month even. The steps that we've taken included just being transparent with our clients. The image that you'll see has an update from May that informed anyone who accessed the survey that our program was still running normally. Both myself and Katie Howder, my backup, who I know is listening in as well, were on weekly deployment in another health district in another region of the state to help with COVID-19 case investigation and contact tracing between March and August. So in addition to the increased volume of requests we were seeing, we were also working quite a few hours and spending quite a bit of time physically in another region of the state doing a totally different job. And so we would update that notice every week, just saying that the program is still running normally. And fortunately, we were able to keep the program in daily operation throughout throughout our assignments. During 2020, we were able to launch a couple additional features. In mid-June, we widened our eligibility criteria. So the picture that you're seeing is actually before we widened our eligibility to include cisgender women. So that image is slightly out of date. We also launched our Spanish language implementation. We began offering clients the opportunity to indicate if they would like a automated eligibility reminder that they would receive by email. And we enhanced our ability to kind of manually assist clients getting from a positive self-reported home test to a confirmatory test at another provider. So I just wanted to give you a sense of what our 2020 data looked like, since I said we had quite a pronounced increase. We had a 110% increase in 2020 over 2019. We went from just under 900 test kits to just under 1,800 test kits. And you can see that those were split across Virginia and Maryland. Maryland requests make up about a quarter to a third every month of the total request volume that we received. And their kit volume more than doubled from 2019 to 2020 as well. As far as repeat users of the program, 237 clients used the program more than once during 2020, and an additional 226 clients who used the program in 2020 had used it at least once in an earlier year. So we're looking at about 35% of our clients who repeated their use during 2020 or were repeat users year over year. And that's just the quick background that I wanted to share with you guys, and I'm looking forward to our conversation.
Thanks, Brian. Really appreciate you giving us some of the numbers and updates on how your program has been going. Really appreciate hearing about Virginia, since your program started before the most recent pandemic, right? And so y'all have some knowledge that you've built over the last several years that has really been helping drive programs in the current moment. And I want to bring up our third speaker, Joshua Cody Knight. I'm really grateful that you're here, Joshua. I first heard about Joshua's work in a webinar, actually, where you were talking about self-testing in Native communities. And it was important for me to bring your voice here, and also because I know that Oklahoma sometimes doesn't get as much love as it deserves, right? And so I know you're also working in somewhat more of a regional way in your area. So Joshua, if you can tell us a little bit more about yourself and about the HIV self-testing work you've been up to, and the floor is yours.
Yeah, thank you so much for having me. I want to give a little bit of background on my office is not a traditional Department of Health like the other two presenters, and I'm super interested in the data. I saw a comment just come up. So my office, I work for the Southern Plains Tribal Health Board, which is the governing board that is over the Tribal Epidemiology Center. There are 12 other tribal epidemiology centers across the country. So each one is governed by a board, which is made up of representatives of the service areas. So the United States for indigenous populations under Indian Health Service is broke up into service areas across the country. Specifically, the area that my board and epicenter are over are Kansas, Oklahoma, and Texas. So 44 federally recognized tribes reside within that service area. And so this is the target population that my office specifically works with. I work on a national coordination scale also within the National Native HIV Network. I'm on a couple task forces that make up representatives of the federal government, IHS, and then other regional pieces. But I specifically want to talk about the breakdown of how IHS, tribal run facilities, and urban Indian clinics work. So within how an Indigenous person can access healthcare in a non privatized, I guess, system, Western way. The Indian Health Service has clinical sites, for example, across Oklahoma. There are a few IHS, Indian Health Service hospitals, and then there are other clinics. So those are one access point. We also have tribal nations that are designated 638 tribal facilities. These are tribal nations that have taken over administrative control and operations of the former Indian Health Service hospitals that were servicing their area. So now they run all the administration and operations of their own health systems. Then you have the urban clinics. So there's one located in Oklahoma City and there's one located in Tulsa, Oklahoma. There's also a Dallas. I'm focusing on Oklahoma to try to keep it simple. But so there are 3 access points, and not only with there being 3 separate entities there, they all run with different, criteria and access points of running programs. And then within the tribal facilities, each tribal nation is a sovereign nation, and they govern and administer operations of their health facilities independent. They make their own rules. So there's not a if I access one tribal facility to help run a program, say specifically for age has been something that has come up for the self-testing. The criteria for one tribal nation for us to run self-testing may be 18 and over, whereas at another tribal health facility, the age criteria may be 15 and older. So that is something that is decided by tribal council, tribal governing board, health system governing board. So that's a very unique way I and my office pivot amongst the health access points for Indigenous people. So on that note, self-testing came about because of the pandemic, as it did for most people. But before, obviously, some people were running it before, and that's amazing, very exciting. But as was mentioned, Oklahoma sometimes is a little bit behind the curve, but me and other great people across the state are trying to work to, bring us up to speed with everything. So I was actually working specifically in a hospital setting, clinical sites, helping run a program that did lab triggered screening, emergency department screening, non-traditional sites within the health system. And when the pandemic hit, right at the very beginning, I had launched a text messaging system for PrEP access, is how it came about. And the point was to have a 1-800, someone can text in, get PrEP information, contact a provider, get a pill reminder, or a 1-800 number that we had one of the providers carrying at all times. It rotated. This text messaging system has no data limitations, and that's very important considering the rural nature of Oklahoma. And specifically this community, this tribal nation I'm working with is very rural. It's the majority of its population is in a very rural part of the state and very limited cellular data access. So I wanted to make sure that, using any kind of technology creates a limitation in general. So I wanted to minimize that burden by only, creating a system that can be accessed by one bar of cell data or 1 bar of cell service. And so all of this information can be accessed that way. Well, right about February, March, when everything started really, going the wrong direction, my clinicians that I was working with had to pivot from their duties around their standard practice to COVID. and the health system, shut down in a lot of ways. And so my providers came to me like, how can we continue our testing efforts, because we were making so much headway in an area that was not a priority. And I had been working on this self-testing model through the texting system within my own office to create what I would consider a blanket program for the state of Oklahoma. And then the plan was to make individual programs within each community. So what happened was that fast-tracked the pilot program that everybody can now access to request an HIV self-test kit, coupled with the PrEP access. So when someone texts in, and I'm gonna let you guys, if you want to, you can test out my office's program is not live. So, and I control and can see everything, so you don't have to worry about that, but you can go all the way through that system. It's very simple. You can text and muting back and forth too. And so you text in, it asks you your name. You can still go through the options of accessing PrEP, but then you can also request the self-test kit, which OraSure is the only FDA approved self-testing kit that you can use, like mail out, like we are doing. So that was, and the process of talking about the individual sovereign nations' restrictions around this was a conversation where the age of 18 and older, we were allowing access to anybody can access it, but 18 and older. So there's a question that asks about your age for that pilot program within that specific nation. There is one for our office, which is going to be adjusted to allow greater access. But right now it's just the skeleton. So with these testing kits, when someone gets it, you get information about PrEP, U equals U. I had a video created that gives a visualization of the manufacturer's details of how to run the test, with an indigenous person being the actor and the prompts behind it. This can be accessed through a QR code, which is you put your camera over it, which, yes, I know is a data restriction, but that is a piece that we use there. And then there's the hotline number. We have another little postcard that talks about texting back in to talk about PrEP, STIs, and linkage to care and pieces like that. This is a very unique pilot program because all of these things are bundled into one central source. Like whatever you access out of that comes back to that one clinical site and is roped into 3 providers. That's not going to be the case for the blanket program that is going to be run out of my office, which is going to cover the whole state. So it's very important in my work that I make sure that I am serving the communities in their tailored way, but also I wanted to make sure that the entire state is covered in case there's someone that's, accessing this away from what would be a healthcare point for them, and with limited PrEP providers and, HIV care within the state of Oklahoma, that creates a problem too. But so all of the linkage to care in those places for that pilot community program is centered around one group of providers in a healthcare system. I wanted to also mention for our office model, we have coordinated with the Oklahoma City Urban Clinic. So that's based out of Oklahoma City, and they will be the PrEP access point because they are offering telehealth for PrEP. Teleprep, I guess, is the term we're all using. Teleprep, and they're able to be accessed. They're a central location, and they have a few more operations around reaching out to individuals, across the state. And there's no there's no connection to one group of indigenous people by the urban clinic. It's not Cherokee Nation or Choctaw Nation or Seminole or Creek. It's one. And so on the blanket program, the urban clinic will be coupled with our state linkage to care. We have a very integrated group of case managers that work for the state that are familiar with our tribal systems, the IHS system. And so they are going to be the linkage to care because they're most familiar with linkage to care across the state of Oklahoma. So it's very interesting. I need to speed up, I'm sure. So numbers. Currently, the pilot program has mailed out over 300 test kits for that one community. We at about 250 so test kits, we linked our first positive to care, which I know talked with the other presenters. Traditional ratio is about 1 positive to 1,000 tests run. So this is a very promising model. And I foresee as we are launching the blanket program at the office. We also have another tribal nation that is going to launch this specifically for their healthcare system and their citizens and their service area. And so I see eventually us having a very, is it spoken wheel model or something in the fact of, I want there to be a blanket program that covers the whole state to fill the gaps. But this is definitely, it's an important thing to make sure when you're working with indigenous populations and nations and governments that they will be in control and be able to tailor because they know their citizens, they know their people the best. And so that is what my office is, that is my office's purpose, is to facilitate and grow infrastructure and capacity within our partners, not control what is done. So I'll be quiet now so we can actually all talk.
Excellent. Thank you, Brian, Joshua. Sorry. I really appreciated that. And I texted the phone number actually, and I got a live message back. So this is really awesome. I hadn't seen too many texting services about it. You can't see it on the monitor. My apologies. But I hope other folks got a chance to text that number to see some of the work you're piloting. And you, I want to start opening it up to the conversation to our other speakers as well. You were just talking about this, Joshua. It was about some of the partners, right, that y'all were working with. And I wanted to see if y'all could talk a little bit more about some of the traditional or non-traditional partners that y'all collaborated with in this work. I know that something I saw in the context of Virginia was that they recently updated that survey form to include folks who live in Alaska, right? Which is not next door to Virginia in the way that Maryland is. So I was curious about that, Brian and Bob. I know that in Tennessee, y'all had been collaborating with Gen Hecht and building healthy online communities. If you want to speak a little bit about some of those different platforms as well. And Joshua, if you want to just add a little bit more about some of your hopes for how the work that y'all are piloting can be a model for other places as well.
So Jose, I think that the way that you have sort of framed the question, I think really kind of outlines a couple things that I was thinking about in relationship to the partnerships that we've formed, or I think how different states have tried to adapt home testing into our regular testing models. So Virginia actually, so our program with the Virginia Health Department doesn't actually serve Alaska, but what you're seeing there is a kind of a network of home testing programs that are kind of linked. So we have an agreement with the Maryland Department of Health to serve Maryland residents. Separately, there's a research program at Johns Hopkins called I Want the Kit that services DC residents, Maryland residents, DC residents, Baltimore residents, and Alaska residents with HIV self-testing and STI self-testing. And then separately within Maryland, there are several local health departments because of direct funding from CDC that have been able to launch their own local home test distribution programs. And because of these different programs that are working in the same area, we've come together as a regional group. So we've had several conversations just to think about how our programs play off each other and feed into each other. So for instance, in our REDCap data collection tool, if someone marks that they live in Maryland, because our program only provides HIV self-tests, that person will receive an additional sort of text field that will appear that refers them to I want the kit if they would also like to request a STI self-test kit through that program. And, you know, Bob shouted me out, which I really appreciate. And one of the things that I've kind of enjoyed, it seems weird to say that I've enjoyed anything about 2020, but home testing programs have proliferated so significantly last year. And I got a lot of gratification from just developing relationships with my peers in other states that were launching home test programs or who already had, and now I was, you know, getting to learn about their programs through other webinars. We still have clients from other states who try to access our program, or Virginia or Maryland residents who let us know that they're moving to other states. So it's been really helpful as that process kind of unfolds to already have relationships with those people in the states where they're moving and awareness of how the home testing program in those states works, so that I can make, you know, informed.
Sorry, could you slow down?
So that I can make informed and accurate referrals to those clients for their new home state. And I know in my presentation that I spoke about our sort of central office home test distribution program, but we also have a totally different program where community-based organizations distribute home test kits. And I actually borrowed heavily from the system that Bob is using to develop the procedures from that program. So I know a couple of our community-based organizations are listening in on the webinar and probably recognized elements of the system that Bob described, because it's what we're using for them right now.
Thanks, Brian. Wanted to see, Bob, if you wanted to shout out some of your partners as well, or add anything to the question.
I just wanted to briefly mention the Building Healthy Online Communities pilot that we participated in. It was awesome. It was app-based, and I think looking at the numbers that Jen sent, I think 90% of our tests were distributed through Grindr. Jen sent a detailed information on each test at the end of each month, and I kind of cross-checked zip codes, and you know, those tests made it to folks in towns in Tennessee that I'd never even heard of. So, like I said, I think almost our entire allotment of test kits were requested or distributed or within 12 hours. I received a low inventory email. I think that the program kicked off that morning, and I received a low inventory email that evening, and I thought that it was a mistake, you know, just a you know, a glitch in the system. But talked to Jen the next morning. She said, I think, and I double checked the numbers, but I think 283 of the 300 tests that we had allotted for or had purchased were already requested. So it was great. I think the only limitations of that pilot were that you had to be over 18 and not have tested within the last year. But I think those restrictions have been loosened just a little. So I have to check back on the details. But yeah, and then, like I said, that just kind of indicated that there was a of course, there was still a need for HIV testing during the pandemic in Tennessee, and that really got kind of kick-started the rush to get a self-testing program in place so that our community-based organizations could still provide, HIV testing services to the folks that needed to be tested.
Thanks for adding some of that context. I put a link to building healthy online communities in the chat. Jen Hecht, Dr. Jen Hecht, based out of San Francisco, is the lead on that project and has made herself available to talk to folks who are interested in using that platform to be able to launch or continue their self-testing programs. Joshua, I want to see if you'd like to add any more context around your partnerships. And also wanted to encourage y'all to see if you have any questions for each other, right? We really want this to be a learning community. And with this particular roundtable, we have from the East Coast to as far west as the South is considered, right? Oklahoma, I believe, is like where you start getting into the Midwest technically. So we have a full range, geographic range. So I wanted to see if y'all have questions for each other as well.
I did see one. I've been trying to go through the chat again. Somebody mentioned about what tribes I've been working with. And so specifically, right now, the pilot program was ran out of Cherokee Nation. Currently working and about to launch with Muskogee Creek Nation. And then our blanket program for the state, and now with a national push from some partners, we're going to be working with the urban clinics for that. So traditionally with other partners, so for the blanket program, the Oklahoma State Department of Health has been helpful because they are going to try to, off of the model we're running out of our office, they are going to try to launch their own self-testing program. And traditionally working with the tribal nations and then also trying to coordinate in state efforts and stuff, it can sometimes be a little difficult, and as for good reason in some ways. And so that's a very interesting piece. And then also thinking about Indian Health Service, IHS is a federally run organization with quite a bit of bureaucracy and very, it's a very there's not a lot of pivot, I guess is what I should say. And it's because it's a hardened system. It's been around for so long. So those are partners that we are working with, but it's a very unique situation working between, a federal entity, sovereign nations, and then also the urban clinics, which are in a way, their own governing body. And so it's an amazing partnership. Believe me, it's incredible what comes up with in meetings, but it's also very unique that I think creates, it makes you deconstruct kind of the Western way of how systems are in place, and how we've always tried to approach a lot of stuff from a blanket oriented or like a serve all, kind of mindset. Whereas now breaking this down into making sure communities can serve their own communities, I think is an empowering, and I think it's something that can provide sustainability also, because you're making local stakeholders. Because I think that's one of the questions was any pitfalls, best practices or pitfalls. I think especially in Oklahoma, not creating champions and stakeholders within our communities has been a big problem with sustainability around these programs, because of how hard hit they are with criticism. And you know, state legislation and different things like that. So sustainability is something I think that's always important in this area for especially Oklahoma and our rural areas.
Thanks for that context as well, and I definitely think it is important to find those champions for self-testing and just prevention and care in general, right? Also wanted to name that something that Brian had brought up was that when you launch this program, if it's going to exist in the digital space, that means that many people beyond your jurisdiction might have access to it. And so while doing some of this work, we've seen that many self-testing programs, they'll have a website, you know, and it might be based in a particular city, but they'll get folks from across the country reaching out to ask for a test. So when we're developing our protocols, what are we going to do in that context, right? Do we just send them no? And it sounds like Brian was saying that the red cap form that they have, which is a particular type of survey, actually links people to some self-testing services in other areas. So that might be something to think about, even amongst the three of y'all, right? How we can start referring each other to surveys, because we know that there are Indigenous people everywhere across the South, right? And we also know that there are people who want these services across the South as well. I wanted to see if we have any questions from the audience. I know folks have been answering them live. And while we do that, I'm going to put a link to one of our capacity building cousins, so to speak, which is the Denver Prevention Training Center. They have a great website up where folks can see various HIV self-testing protocols. It includes Virginia's protocol as well as LACOA's, because the commission has actually had a HIV self-testing program since 2015 that it piloted based out of New York City. So that's available to review. I know that Denver is going to be publishing some more material around that as well. So we'll be sure to share that with the participants. But wanted to see if we have any other questions for each other or from the audience while we're here as well. But ask y'all to see if y'all could also share your protocols. I don't know, Bob, if Tennessee's protocol is something that would be public, publicly shareable, or something that could be transferred to some of the other partners that in the South. I know you said that you were also keeping some of these test kits in your closet and building up, you know, the infrastructure there. So I would be interested to hear more about what support y'all need as well.
Well, that was just one of the, you know, the general logistical issues that, I've been working from home since March, so I had all of the, for the most part, we were able to drop ship most of the test kits to the CBOs, but then I needed some, I had quick access to just in case. So I turned my kind of bedroom into a storage facility of test kits and boxes and all that kind of thing. But I think I can share our protocol, and ours is pretty short. It dealt more with reporting and evaluation web and that sort of thing. But I'll check and see if I can share that. I'm pretty sure I can.
Thanks. And I know that a lot of folks are really interested in the flow chart, particularly, right? Which also makes me, encourages me to ask what kind of training y'all were providing for your staff as well to be able to work on this. I know that y'all were champions at your own agencies. Something that LACOA, for example, did, the Latino Commission on AIDS did before starting their program was they did a social media training for all of the staff, right? Because we were going to be navigating the virtual space. The first step was a social media 101. So I'm curious to hear if what other kind of training y'all might have experimented with.
So I have a unique. Oh, go ahead, Brian.
I was just going to say, we didn't do any particular training related to self-testing internally. And I thought, Cody, your point about stakeholders was very interesting, because I do feel like self-testing has been a very democratizing experience for like me personally with the agencies that that we work with to do HIV testing in the community. You know, even though I've been running a home testing program for about 5 years now, the move to having community-based organizations distribute so many of our HIV self-tests was a new experience. And so I think it did feel like I was on the level with, you know, the testing coordinators at the agencies who were distributing those tests. So I've, you know, reached out to them, the folks at several agencies, when I've been curious about what are the best practices if you're doing this at a community-based organization or at the point of care, rather than, you know, sitting in an office sending out test kits by mail, which is what I'm doing. So we haven't done any training, but I feel as though I'm sometimes receiving technical assistance from the organizations that I would normally be funding and giving technical assistance to for HIV testing.
That is spot on, and because that's what it wasn't. It was almost reverse, because I would be working with, you know, say it was just unique to the individual structure of whoever I was working, what partner I was working with, and how do we need to pivot and, you know, cater the way we present the texting, because we have different prompts. So Cherokee Test, Cherokee Prep to a number is one. Creek Health, Creek Prep, Creek Protect, that's going to be one. And the messages you receive are all tailored. These communities, these health systems get to tailor all of that. And that's how it kind of has come back to me. It has been, in a way, how Brian said, like a technical assistance, like reverse. The only trainings that I'm going to say that we've really talked about is if they are going to put their own materials in and kind of cater their own stuff, the health literacy pieces of it, working with the Mobile Commons software, which I apologize, that's the texting software that we've contracted with to run all these programs. Upland Mobile Commons is what it's called. So teaching around that. But Brian's right. It's been, you know, it's been kind of a reverse of learning how to work and tailor things and what works best with this community and doesn't with this. And, you know, what do we do if it's a PO box and it's not an actual address? What do we do if it's definitely been eye-opening and just definitely beneficial to move to a less centralized system.
Excellent.
You know, I wonder, Cody and Bob, if you would agree. You know, I was thinking about pitfalls and recommendations for organizations that are considering doing an HIV self-testing program. And there are sort of two things that I think have come up over the years that I've had to kind of check my own mindset about what the purpose of the program is. And the first one is like the concern that I hear a lot about, what do you do if a client tests positive and like has a mental breakdown, which isn't something really that we have seen. I think, you know, people should be given space to have the emotional reaction that they're going to have. And I think that that's actually one of the benefits of self-testing, is that they get to have that reaction at home and process it themselves and not have to have it in front of a stranger or in an unfamiliar space. And we've heard that from clients as well who reported positive self-tests, that they appreciated that space. And then the other piece is like clients who try to manipulate the eligibility or like abuse the system or like, before our eligibility criteria expanded, we would have requests that obviously came from cisgender female clients, because we would see several requests with female sex at birth, female current gender, and then they would get that exclusion criteria message. And then we would see like a fourth request with the exact same information, but it was just changed to male, and the name is still a female name, and it's obviously a cisgender woman. But at that point, I've always had to stop myself and think, this person is going through a lot of effort to get a test that they clearly are telling me that they need. And the purpose of the program is to expand awareness about HIV status and help people who would otherwise be too stigmatized to get a test, maintain that awareness. And I kind of wonder if y'all have had some of the same experiences with your programs. I know, Cody, especially with you, the dealing with tribal nations, I'm sure presents a unique challenge in and of itself.
So I think we have 2 minutes left. I just want to make that clear, Jose. Is that right?
Yeah, we'll try to end soon so that we can just respect our interpreters. But yeah, if you want to just give some brief comments, and hopefully we can facilitate a learning community later on as well, if folks are interested.
Yeah. So with the tribal nations, the conversation was had about that, about criteria to be able to access. After a lot of conversation and a lot of data presentation and pieces like that, there is no criteria but age. Age is the only restricting piece, and even then, they just have to put in their age. So that can be curtailed in a way. But that for the eligibility thing, and then also kind of what Brian said about someone, that was a big fight between like the traditional way, like CTR of testing, and then the self-testing. And it was just making sure, when I'm talking with the communities, I'm like, just make sure that resources and like the numbers to call, places like that, if you want to do follow-up, we'll work on that, but just make sure no one feels left in the dark. At the end of the day, knowing your status is better than not knowing your status, but also it's better to know you're supported with your status than just being alone with it. So whether that's reached out, like if the community decides that they are going to do the outreach to these individuals who've requested the test, if they're just going to allow to have the resources in the testing mail outs so people can call in and talk about it, making sure a crisis number is in there. Those are the pieces that I think have created that blanket of protection.